Hi everyone, welcome to this free Vulval Pain Society webinar number 9 in this series where we ask the experts to answer your questions. I'm Sheren Gaulbert, Trustee of the Vulval Pain Society and Pain Science Educator. We've covered a range of topics, disciplines over the last 8 weeks. Please email info
at vulvalpainsociety.org.
if you'd like to find out more about what we've covered or would like access. So you've asked us to continue these webinars, so we asked you to choose the topics. Today, menopausal wellness and pelvic health. Now, before we meet our expert, let me tell you, as usual, we have Kay Thomas from the VPS in the Q&A chat boxes. Many of you entered a question when registering, so we're going to see whether we can get to answering as many as possible. There's a lot to get through. We do tend to get a mountain of questions, but this time, interestingly, there's a real variety of questions that have come in. It's really astounding. So it kind of points to the complexity of what we're covering today. So look, this is probably going to be part 1 of a series when it comes to menopause. If a question comes up as a result of something that is mentioned, then do type in the Q&A box and we'll see whether we can cover it if we're not already going to cover it. The other thing I will say is if something comes up and you have a personal or a professional experience that might help someone else, you can type that in the chat box and everyone will be able to see that. So completely up to you. So familiarize yourself with the 2 boxes, the Q&A boxes if you want a question answered, the chat box if you think you've got some experience that might help someone else. So we talked about the complexity of this area. So I'm really excited to introduce our expert today, someone who doesn't treat just a symptom or a body part, but the whole woman. I love this. You're a true proponent of the biopsychosocial model of health. Women's health physio, you've got a knowledge of nutrition, herbal medicine, mindfulness, yoga, so much more. Michelle Lyons, welcome.
Thanks so much for having me. I'm absolutely delighted to be here today.
So excited about this. Before we get into the questions, I'm going to run a poll to see who's with us today. So if you, and this is multi-option, so you can pick more than one. Perimenopausal, menopausal, just want to plan ahead, healthcare professional or other. So as that those results come in, just to say some of the questions you sent in might be more appropriate for a medical doctor to answer, so we'll kind of set those aside for the future. Michelle, as those results come in, tell us a little bit about you and your day-to-day work.
Sure. So I qualified as a physio 27 years ago. At this point, it feels like 150 years ago sometimes. But I've been working in women's health really for the past 20 years. And it started with, my career started out in sports medicine and orthopedics, but with the birth of my daughter 20 years ago, I didn't have a great obstetric experience, and I thought we have to do better by women and, be the change that you want to see in the world. Yeah. So I changed career direction and really became very passionate about all aspects of women's health, because women's health is, there's a certain phrase when we talk about women's health, bikini medicine, and it really just, tries to compartmentalize women's health into breasts and pelvic health. And I think that's really doing women a disservice. We have to look at the whole woman, her story, her history, how she's doing, what's brought her to this point in her life, how she's living her life, and then, of course, what we can do to help her live that life better, and to really improve her quality of life. So I think, we have to look at all the different aspects of health. Physical health, certainly. What's she eating? How's she feeling? How's she exercising? Does she have pain? What are her physical and mental stressors that are going on? What's her healthcare journey been like up until now? What are her main issues and problems and, desires for living well? And so I really have focused over the past number of years on building out a toolbox that's hopefully going to tick a lot of those boxes for women. And for most of the past 10 years, I've been teaching at a postgrad level on women's health. So going back and forth to the US and Canada and Australia, the UK, with the delights of a global pandemic. I'm putting more and more of those informational and educational resources online. And I collaborate with my good friend Jenny Burrell in the UK, and we've put together a number of different courses that really try to look at the health of the whole woman, body and soul, because I think if we're just looking at one body part in isolation, again, we're not getting the big picture. So we can zoom in and be really specialist, but we want to be able to zoom out and see the whole woman as well.
Yeah, brilliant. And the poll results are in. So we've got 24% perimenopausal, 29% menopausal, 11% just want to plan ahead. Love it. Healthcare professionals, 47%. And then other. Now, if you want to tell us what that other means, that's 15% is other. So if you want to let us know what that means, you can definitely type in the chat box and let us know. So we've got a split between patients and clinicians here, it seems. So shall we dive into some of these questions? And as we start, can we distinguish between perimenopause, menopause? How do you know that you're starting either one or transitioning from one to the other?
So the thing about menopause is technically menopause just lasts a second, because menopause literally means it's been 12 months since you've had a period. So you don't know you've been through menopause until a year later. So if you've had a period and then you've had 12 months without bleeding, technically you are in menopause. Perimenopause, on the other hand, is that, for some women, it's just a couple of years. For some women, it's up to 15 years of the build-up to that snapshot of time where it's been 12 months since you've had a period. And that's when a lot of this is going on with our hormones. They're up and down. We're trying to figure things out. But generally, worldwide, the average age of menopause for women is 51. So if we go 15 years back from that, if you're over 35, for most women, you're in that perimenopausal zone. So it's really, menopause itself, like I said, it's just a blip, but it's perimenopause. And then, of course, postmenopause, because we're going to live somewhere between a third and maybe even up to half our life after menopause, depending on what age we are when we have it. So our job is really to make sure that women are living well during and after menopause, and that we're using all the different tools at women's disposal, to really take charge of their own health. I'm a big believer that knowledge is power. And by having really open, frank discussions about issues that might have been taboo in the past, like menopause, when we used to just refer to it as the change, shh. And just to be able to, it's not a medical problem. It's a normal life transition, but we have to look at the context in which it's occurring. What's going on, nutrition, movement, stress, sleep-wise, hormonally balanced-wise, and what can we do to improve the situation if it needs improving?
Okay. So in terms of preparing for menopause, we've got questions on preparing, and of course there are the people watching today who are thinking ahead. Should we start preparing for menopause before we enter the menopausal years? Can anything help prepare?
Absolutely. So a couple of things that we can do to ensure a good transition through and beyond the menopause. And I would say one of the most important things that you can do for yourself as a woman at any life stage is to prioritize your self-care. And it's one of those things that's really easy to say and quite difficult to do sometimes. But if you are bringing an element of mindfulness to every decision that you're making, then the dominoes will line up behind that as much as possible. So making good choices about the food that you're eating, about your stress management. I think that's absolutely vital for hormonal balance, because when we're approaching that menopausal switch, we really want to think about, yes, we've got declining levels of estrogen and progesterone, but your body has other reservoirs that it can convert these base hormones into weaker types of estrogen as well. So as ovarian production slows down, our other avenues of hormone production have the capacity to ramp up a little bit. But if those building blocks are being diverted into the production of stress hormones instead, then we have nothing left in the tank for that conversion. So that's really important. Self-care, stress management. I would say sleep is essential. It's a really essential part of good hormonal balance. And movement is just non-negotiable once you're a woman, first of all, but certainly once you're in perimenopause, movement is absolutely non-negotiable. Because when we go through menopause, we lose, estrogen has about 300 different functions in the female body, but a couple of its really important functions are, of course, pelvic health, but heart health, brain health, and bone health. And what we know is that there's a huge body of evidence to show that lifestyle approaches like sleep and stress management and nutrition, but primarily exercise and strength training especially, jumps out as being protective for your brain, your heart, and your bones. And I think, there's also some interesting evidence that it's very protective for your mental health as well. So those are really the big rocks of living well coming up to and beyond menopause. How are you managing your stress is a huge one, because if you're diverting those building block hormones to stress hormones, that's one thing. You're not going to sleep well. That can lead to heart problems, but that can also lead to weight gain. It can lead to pelvic health issues as well, because our pelvic floor muscles are such a psychologically responsive part of our body. So if we're feeling tension or anxiety or fear, we're going to carry that in our pelvis as well. So if you can get those 4 building blocks, if you can give those 4 your attention, you're in a really good position to start taking charge of your perimenopausal journey.
Okay. Good advice. Great. So diving into a few more of these questions, can you have signs and symptoms that are typically associated with menopause, but not be in menopause because you still have your period?
Absolutely, especially once you're in your 30s, because that's when we start to notice some changes. And I think particularly what we're seeing now is that women are having babies later in life as well. So it's not unreasonable to assume, to acknowledge that there are many women who are both postnatal and perimenopausal at the same time. And that's a huge challenge for all the systems in their bodies as well. I think in the past, maybe, a lot of issues that women have had at midlife were blamed on the menopause. It was just this catch-all for everything that was going wrong with you. And I don't accept that as a good enough strategy for helping women. I think we have to be able to look a little bit deeper. Sometimes thyroid dysfunction can mimic some of the symptoms that we associate with menopause, like brain fog or hair loss or hot flashes. So I think we have to really look deeper for answers and make sure that we're not getting the brush off or being told to go home and have a glass of wine and relax. It's really important that we can advocate for ourselves as women and that we educate ourselves and we're able to say, I want some answers as to what's going on. Having said that, that doesn't mean that you abdicate responsibility to a pharmaceutical. That you really do have to take responsibility for doing the work yourself on those lifestyle aspects that you can control as much as possible.
And those lifestyle aspects, you talked about movement, and there's a question here, is there a connection between the menopause and increased vulnerability to aches and pains and muscle strains?
Absolutely, I'm so glad you asked that. So we talked about the hundreds of different things that estrogen can do. And one of the things that estrogen has a huge influence over, as well as bone health, is actually muscle and tendon health. So lots of women going through menopause start to notice aches and pains, their shoulders, their hips, their feet, their back. And we see this actually even more so in women who are going through breast cancer treatment, who are maybe on estrogen reduction strategies like tamoxifen or aromatase inhibitors. They can really get some strong muscle and joint problems. And again, you know, I'm such a one-trick pony here, but the answer actually is a specific exercise strategy. So we know that, say, for example, women in their 50s, 1 in 4 women in their 50s will develop an issue called gluteal tendinopathy, which basically means you're going to start having some problems with the tendons around your hips. And oftentimes, this is misdiagnosed as hip arthritis, but it's a tendon problem. And tendons love estrogen, and they really don't like changes in their environment or changes in activity. So if you're a woman in your 50s, what happens around midlife as well as our metabolism changes a little bit. The things that we could get away with eating in our 20s are possibly not as well tolerated in our 50s. We put on a little bit of weight, and maybe we go gung-ho into a new exercise program. And we can develop just little strains and aches and pains. And then we think, oh, so exercise is bad for me. I'm going to stop doing that because now it's hurting me. So the key is to find the right type of exercise for where you are in life. But we have really lovely evidence showing that for these women who have this gluteal tendinopathy, and again, 1 in 4 women in their 50s are going to develop this, we need to have women who are capable of seeking an accurate diagnosis, first of all, whether it's from their physio or their GP, and then getting the help they need to take care of themselves. But we see issues with shoulders, with rotator cuff issues, plantar fasciitis. So yeah, I mean, the reality is that your tendons do miss having estrogen around, but there's a lot that we can do to help them out, to help them stay strong and supple. And, you know, motion is lotion. Physios, we love good cliches around exercise, so I apologize in advance. But really, it's how we keep our bodies happy and healthy. And again, the evidence is really starting to build up that it's how we keep our minds happy and healthy as well.
Yeah. And I love that phrase, motion is lotion, because really it's kind of telling you that it's no one exercise, it's whatever suits you, whatever movement suits you.
And whatever you like doing.
Yeah, absolutely. Yeah.
Yeah. That's key. Because if you don't enjoy it, you're not going to do it.
No, exactly. So estrogen having lots of different functions in the body, is there a connection between menopause and the activation of autoimmune diseases?
Yeah, that's an interesting one. The jury is still out to a degree on that. But we do know that one of the key populations for, say, autoimmune diseases like rheumatoid arthritis, for example, women in their 40s, in that perimenopausal zone. We know that stressors can be a driver of autoimmune flare-ups as well. Yeah. So depending on what your interpretation of going through menopause is as well, menopause can either be a cultural stressor for you, or it can be a cultural joy. You know, if you look at the research from around the world in cultures that actually respect women as they get older, if you view menopause as a time where maybe you don't have to worry about birth control anymore, that you're a little bit more free, maybe the kids have left the house, maybe you have the house and your partner to yourself, maybe you've gotten rid of the partner as well, and it's a whole new phase of life for you. I think a lot of that, you know, every thought that we have produces neuropeptides, and every cell in your body is listening to the thoughts that you have. So there are definite physiological issues with autoimmune dysfunctions like rheumatoid arthritis, but I think we can't discount the effect that psychological stressors, as well as nutrition and all the other things that are going on, but we definitely see autoimmune dysfunctions affecting across the board women more so than men. So I think there has to be some hormonal interplay there.
Okay, all right. Question about hot flushes. Any tips to decrease them, alleviate them?
Yes. So here's what the evidence tells us. that practicing mindfulness and using cognitive behavioral therapy can decrease the frequency and intensity of hot flushes by 46%.
Wow.
But I know, I mean, these are great numbers, and the side effects of, compared to medication, the side effects are usually pretty good.
Yeah.
It's a matter of building up your mindfulness muscles, though, because some people try mindfulness once and like, oh, it didn't work, I'm never doing it again. But you wouldn't go to the gym and lift a set of weight once and say, oh, my arms don't look like Michelle Obama's. What am I going to do? You have to do the work and build up your mindfulness muscles. So that's a really strong evidence-based strategy. The other ones are giving up alcohol, coming up with a good sleep strategy. And again, to sound like a broken record, exercise has been shown to really help with your thermal regulation, particularly cardiovascular exercise where you get your heart rate up a little bit. It really seems to improve that temperature regulation. So a combination of exercise, stress management, avoiding alcohol, and then the usual dressing in layers, making sure you're well hydrated is really important as well. And that's one that we see as being a key issue around menopause as well, because sometimes women might start to develop a little bit of bladder leakage as they go through menopause and they start restricting their fluid intake. And that's really disastrous in terms of pelvic health, but also in terms of your hot flush management.
And what can be done for an overactive bladder?
Well, I'm surprised that it's taken me this long to mention it, because if anybody's watching this who's met me before, one of my very, very favorite things to talk about is constipation. And constipation is one of the key drivers of overactivity in your bladder. So for anybody, who's going through any pelvic health issues, one of the first things you want to try and do is deal with any constipation issues that you might be having. And that can be driven by maybe some overactivity in the pelvic floor muscles. Are you eating enough fiber? Are you drinking enough water? Are you moving enough? There's lovely studies out there showing that even a 20-minute walk a day is beneficial in terms of addressing constipation. So don't go straight for the pharmaceuticals when it comes to constipation. Try a little abdominal massage, some deep breathing. Again, look at your stress levels, because the bowel and the brain love to talk to each other as well. And then go see, if you can, a women's health physio who's going to be able to assess your pelvic floor muscles, because not everybody needs to strengthen their pelvic floor muscles. Most women actually don't need to strengthen their pelvic floor muscles. They need to learn to let them relax and to reestablish some good coordination. But some women do need to strengthen their pelvic floor muscles. So going to see somebody who can do a proper assessment and come up with a bespoke plan for you is really essential for that. So for overactivity of the bladder, first step is get constipation under control, get some coordination of the pelvic floor muscles, find out what's going on with yours. Look for any dietary irritants as well. Our friend alcohol and coffee are the two prime ones that we think of when it comes to bladder irritants. But tea can also be a powerful bladder irritant as well. The tannins in tea can be a little bit irritating, because another function of estrogen is to maintain that lining of the bladder, if you like, and keep it nice and elastic. And as our estrogen levels go down, the bladder can become a little bit less elastic and a little bit more irritable. So we want to just keep an eye for anything that is provoking a pattern of irritation in the bladder. For some people, it's fizzy drinks. For some people, it's sugar. But usually caffeine, tea, and alcohol are the big ones that we see.
So moving on to HRT and estrogen, because still talking about incontinence, there's someone here wants information on the use of topical estrogen to help with stress incontinence.
Yeah, absolutely. So the evidence, again, shows that topical estrogen, well, let's talk about what estrogen does for continence, first of all.
Yes.
It's going to really, it plumps up the tissues around the openings in the perineum. So if we're thinking about the perineum, we've got 3 openings in the female perineum. We have the urethra, which is coming down from the bladder, the vagina, and then the anus. And if you have low estrogen, those openings, instead of being nice and plump and staying closed by themselves, and the muscles supporting everything on the inside and the ligaments keeping the organs where they're supposed to be, the tissue can get a little bit thinner and less responsive. So your two main plans are going to be either topical estrogen or pelvic floor physio. But the evidence actually shows if you put those two strategies together, you get better results than either by themselves. So to go talk to your GP or your gynae and get the topical estrogen cream. And what's nice is there's very minimal systemic absorption of topical estrogen when it's applied around the vulva. So it's going to act locally, and then you work with your pelvic floor physio to get a good strategy, and then maybe with an appropriately qualified fitness professional, because we want movement to be a lifelong strategy, you know, that's really going to carry you through. So you want to use the topical estrogen almost as a boat to get you to the other side and to give you a little bit of a head start, a little bit of a kick to get you going. And then your pelvic floor rehab strategies and your global all over body rehab strategies are going to be what's going to keep you out of trouble.
Great. And how about estrogen with lichen sclerosis, topical estrogen, HRT, does that help?
So topical estrogen would not be the first port of call for lichen sclerosis. You'd be looking at, you know, talking to your gynae and doing something like clobetasol, you know, to get the lichens under control first. Some women do use some topical estrogen with that as well. Oftentimes, a lot of the pain from lichens can come from either the labia becoming quite bound down with the lichens, but also some pelvic floor muscle overactivity as well. So that's another situation where you want to get that combination of a pharmaceutical topical, either the clobetasol or topical estrogen at an appropriate time, but in combination with pelvic floor rehab, because there's a lot that we can do in terms of just showing you how to do some soft tissue work on the labia, maybe using dilators to keep the vaginal introitus patent as well. So again, multidisciplinary care for women's health, particularly for pelvic health, really is the way of the future. I think it's not, you know, we don't have to be none of us have to be a one-stop shop for women, and it's about teamwork.
Yeah, absolutely. How about HRT for pudendal neuralgia?
No.
No.
So pudendal neuralgia is just one of the most misunderstood diagnoses out there. The pudendal nerve supplies most of the motor and sensory function in the pelvis, in both men and women. And all pudendal neuralgia means as a diagnosis that there's pain somewhere along the course of the pudendal nerve. There are lots of other nerves in the pelvis as well. You know, you've got your posterior femoral cutaneous nerve, but basically, let me just grab a pelvis here. The pudendal nerve really only supplies this very narrow area here, just over the perineum. So what you want, if you have pudendal neuralgia, is you want to go to somebody who's going to be able to assess you, lumbar spine, hip, pelvic floor, internal and external, and find out what is actually driving the problem with your pain in the pelvis. Is it a muscular problem? Is it an actual physical entrapment problem, maybe after a surgical procedure? So there's a lot that we can do in terms of mobilizing soft tissue, re-establishing movement, using pain, neuroscience, education. Constipation is another big driver with pudendal neuralgia as well. Lifestyle education is a big part of it. Do hormones play a part in this? Well, we know estrogen, you know, can affect pain perception, but it would be way down the list of things to try for pudendal neuralgia. The main thing with the pudendal nerve is to find out what's making it unhappy, and then to calm it down, and then to build up some resilience in the tissues around it.
Okay. All right. And you talked about, someone's asked, is it safe to take HRT pessaries? And I think you're generally saying yes, aren't you?
Yeah, I mean, hormonal therapy has come on an awful lot over the past decade. And generally it has, there was a study that came out last year, and there was a big kerfuffle because the headlines in the newspaper and the media were quite misleading about how HRT is now associated with breast cancer. It's far less likely to cause breast cancer than having a glass of wine every night. Alcohol has a much stronger association with breast cancer. Being overweight has a much stronger association with breast cancer. Having said that, hormone therapy, again, is a boat to get you to the other side. It is not an excuse for not cleaning up your lifestyle in the areas that need cleaning up.
Yeah.
And if it is a local problem in terms of pelvic health, whether that's sexual dysfunction, if you're not producing enough lubrication, if you're having some leakage, then it's in combination with a pelvic rehab strategy. Have you tried good lube? Are you using a vaginal moisturizer? I would try all those things first, because there's minimal systemic absorption of topical estrogen, but there is some. Once you take a medication orally, it has to go through your digestive system and be broken down by the liver and processed and goes through the whole body. So I would look at all of the different aspects and then make an informed decision about what's right for you. But if you're not eating well and exercising well and managing your stress well and prioritizing good sleep, you have some work to do.
Yeah, it's those lifestyle factors again.
It really is. But I'm not anti-hormone therapy by any stretch of the imagination, because there are some women who are so distressed by the night sweats and the hot flushes, they're not able to live their lives. But again, it's a short-term measure to get you out of trouble, and then you use lifestyle to keep yourself out of trouble.
Okay. Any thoughts on HRT in perimenopause?
It depends when you're going through. Like, if you're going through a very early perimenopause, there could be a case to be made for its protective effects on the bones and for the heart. But again, what else is going on? Generally, what we see is that hormone therapy in women who are going through your standard issue menopause, if you like, they want to take the lowest effective dose for the shortest period of time. The longer you take hormone therapy, the less beneficial it is for you. So it's okay for that short transitional period going through, but honestly, it really is about getting your ducks in a row before menopause hits. The better shape you are going into menopause, the easier your journey is going to be through it and after it.
Right. Okay. There's a question that's come in live. Lichen sclerosis seems to appear most commonly at menopause. Why is this? Is that true?
I don't know that that's entirely my experience. I've seen a lot of women pre-menopausally who have it, as well as peri and post. Is there a hormonal driver? Yeah, probably. I'm sure it has a role to play in there as well. But, that's really, it's a situation where you want somebody who's really specialized in vulvar dermatology, because there are lots of different dermatological issues. And my fear is sometimes that accurate diagnosis is not always delivered. Is it lichen sclerosis? Is it lichen planus? Is it BV? Have we got early stage genital warts? Really, really important that if you suspect that you have lichen sclerosis, that you get an accurate diagnosis, and then take it from there. But generally, it can be well managed, again, with that combination approach of pharmaceutical and pelvic rehab.
Right. Moving on to vulvodynia and pelvic pain, vulval pain. So is there a connection between menopause and pain?
Yeah, so I think if our estrogen levels are lower, there are some sources saying that we're more likely to experience pain. You know how they say you should never go to the dentist the first, day one of your period, because, your estrogen levels are just that little bit lower and you might experience more pain. The tissues are a little thinner and a little bit more delicate and can be a little bit more irritable. we have to, we have to look at big picture issues with vulvodynia. I think sometimes we get very focused on the vulva in vulvodynia, and we have to be able to look at what else is going on. Has there been a change that's affecting the mucosal lining? I think for a lot of women, they find that they become less tolerant of certain foods, certain washing detergents, certain chemicals as well. So the tissues definitely have a change sensitivity. Is there increased tone in the pelvic floor muscles because of other stressors that are going on? Vulvar pain and vulvodynia in general, it's such a broad diagnosis. We can talk about, provoked vestibulodynia and try and narrow it down a little bit. But if we're talking about vulvar pain in general, is it because of the lack of lubrication and maybe some micro trauma in around the tissues inside the vestibule, maybe wearing tight jeans, maybe, as I said, like a change in laundry detergent or going to a swimming pool that you haven't been to before? The local tissues have some micro trauma, the pelvic floor muscles go into protective mode in response to that from the brain. And then we just start to see this spiral. So to be a good clinician working with women with vulvodynia, you really need to do some detective work and find out, is it provoked? Is it spontaneous? What else is going on? What are her stress levels like? When did this start? What do you think is causing this? Definitely we need to look at the mucosal tissues, but 90% of women with vulvar pain, with vulvodynia, will have overactivity in their pelvic floor muscles again. And oftentimes that initial trauma, I'm just, how there's always that one person that springs to mind when you have these conversations. I'm thinking of one woman that I was working with who had decreased lubrication. She was still trying to have penetrative intercourse with her husband, but she was developing micro trauma in around the posterior fourchette of the entrance to the vagina that we couldn't see with the naked eye, but when I got my magnifying glass out, we were able to see the little micro tears in there. So of course, when she emptied her bladder, it was getting irritated. She tried putting on some topicals to calm things down. She tried using a well-known brand lubricant that had a lot of glycol in it that irritated the tissues even further. And the whole thing just kept rolling and rolling and rolling. Pelvic floor muscles then started anticipating pain with intercourse. She couldn't wear jeans. I mean, you've heard the story, I'm sure, many times. And so what we had to do was start just peeling the layers off, calming things down, and then building things up, to paraphrase my colleague Greg Lehman. So it is about hearing the story, when it started, and then being able to pull together all of those maybe seemingly disparate pieces together. Is it menopause? Maybe because she had some decreased lubrication issues going on. That might have been one of the triggers for it, but it quickly gathered steam in a lot of other areas in her life. And it is very much looking at the whole person and the whole story to solve these issues. So I'm disinclined to blame menopause for vulvodynia, because I think there are so many different drivers that are possible out there. And I think too many things have been blamed on menopause in the past.
Yeah. And because it's never ever just one thing, is
Never.
it? It just can't be.
Never.
We're just more complex than that. Someone's asked the question the other way. In your experience, has the menopause helped with vulvodynia?
For some women, they start, their pelvic pain does start to diminish, for whatever reason. Maybe they're just more relaxed. Maybe they're not worried about getting pregnant anymore. Maybe they're moving into a phase of their life where they have more financial freedom. They have more job security. The kids have finally left home. Things are calming down in their life. Vulvodynia it's almost like a mirror of what else is going on, I think, to a degree in your life as well. And the rest of your life will either turn the volume up or potentially turn the volume down as well. And I think, I've had a conversation with Sandy Hilton, and Beth Darnell writes about this very eloquently in her book as well. it is about seeking out pleasure in all different aspects of your life, making sure that you're having regular pleasure hunts in your life when you're dealing with any sort of chronic pain. And I think sometimes for women, menopause is painted as doom and gloom and terrible and awful. But for a lot of women, it is actually a bit of a wake-up call, because we realize it's not a dress rehearsal. We're probably halfway through. Let's start enjoying our life maybe a little bit more. You know, maybe that we have now this freedom and space that we can invite more pleasure into our lives. And I think that that's definitely got to play some sort of role in decreasing any chronic pain condition.
It's looking at all those factors again, isn't it?
Always.
Yeah.
Zoom out.
Right, we've got a question here. I've suffered with vulvodynia off and on through the years. I currently have vaginal dryness with tears and very sore perineum. My gynecologist has recommended PRP therapy, platelet-rich plasma therapy. The cost is $6,000. I hate needles and having blood drawn in the first place, but this just sounds awful. Any thoughts?
Well, yes, one or two. Have you tried everything else first? Because oftentimes, and I'm going to make a sweeping generalization here, it has been my experience that sometimes some of my medical colleagues go to a conference or a training and there's a bright new shiny thing and they get super excited and maybe overlook a couple of steps before we try the big new shiny thing. So I would be inclined personally to just take a step back. Have you tried vulva and vagina friendly lubricants, moisturizers, specifically for the vagina and the vulva? Have you tried pelvic rehab? Have you seen a pelvic floor physio who's experienced with menopause and with pelvic pain and with sexual health? How are your pelvic floor muscles? Have you tried topical estrogen? Is it a problem, possibly, of sexual ergonomics? Maybe it's the position that you're in as well. So have you talked to somebody who can, and again, a good pelvic floor physio should be able to guide you through this. It could just be a positional change that's required. Are you using the lubricant properly? Would be another thing, and as well as using the right type of lubricant. PRP it's quite cutting edge. I don't know that there's a huge body of evidence to support it for this specifically. So I would be more inclined to try the less invasive, less aggressive, less expensive strategies first.
Yes, good advice. Okay, on to vaginal atrophy. What can one do to reduce it, if any, when they're perimenopausal, or to keep the vulval skin from atrophy with vulvodynia to be able to keep comfortable and active? Absolutely.
Apart from the things that we've talked about, you know, the topical estrogen combined with pelvic rehab, there's some good research out there showing that doing your pelvic floor exercises properly, she said with great emphasis, can actually improve tissue condition, but also lubrication. So we've some interesting research that came out last year. It was a small study, but we did see about a 30% increase in lubrication with doing pelvic floor muscle exercises over a 12-week period, which I thought was quite interesting. If tissues are atrophying, if they're becoming quite dry and maybe not as plump and as healthy as they used to be, what do we want to do? We want to make sure that we're bringing good circulation to the area. So orgasm is a great way to do that, either by yourself or with a partner. Doing some soft tissue mobilization, again, with a nice vagina-friendly lubricant can be really good. So if we think about, you know, our vulva and we're just massaging the tissues very gently in and around the labia, bringing a little bit of, I mean, if you do your forearm, if you just press your forearm and release it, you'll see how it goes white and then it goes pink again as we get a little bit of capillary refill. So doing some gentle self-exploration and self-massage in a in a non-sexual way even, can really help bring some circulation and some elasticity to the tissues. Generally, again, a combination of topical estrogen, of pelvic rehab, and of specific pelvic floor exercise, really important to that. You want to stay away from anything that's going to irritate the tissue. So cotton underwear, avoiding jeans that have a very tight seam in the crotch. Fresh air is fantastic for vaginal and vulvar health. So, you know, let those tissues breathe, but get them moving and make them happy, because the female orgasm essentially is a series of rhythmic contractions of the pelvic floor muscles 0.7 of a second apart. So it's a great way to bring blood flow into and then out of the area again. So you're literally building resilience from the inside out. And then by doing a little bit of soft tissue mobilization yourself to the labia on the outside, on the inner thighs, sometimes, I'm just trying to see if I have my little demo one here, using something like a vibrator, but using it externally on the tissues around the labia. So just even, you know, very low frequency, nice and gentle, again, just massaging those tissues can be a really nice way to bring a little bit of health and wellness back into that often neglected part of the female pelvis. It's not just about what's going on inside the vagina. You have to look at vulvar health as well. And the other area that often gets neglected is the hood of the clitoris. So when our estrogen levels are low, sometimes the hood of the clitoris can't retract properly, and it can get bound down a little bit there. We call that clitoral phimosis. So just being able to very gently move the tissues around the hood of the clitoris back. Again, a little bit of topical estrogen can be quite useful for this, but you can use a lube or a moisturizer. Just one quick word of caution about lubes and moisturizers. If it's a new to you one, always do a patch test on your forearm first, 24 hours ahead of time, before you put it anywhere near your vulva. Because I would much rather you have a reaction up here than down there. So just do check, because different people have different sensitivities to those compounds. But bring some attention to the area, exercise it, either orgasm, but just even going for a walk is a great way to make sure that you're moving the circulation, both lymphatic as well as vascular, through that area. And again, avoiding constipation is really important, because if you have that kind of stagnation in around the center of your body, if your bowels aren't moving properly, that is really going to impede circulation in around the pelvis.
And I think from when you talked about the lifestyle factors and looking after all of those, it's answered quite a few of these questions. You know, any advice for women who suffer daily symptoms caused by vaginal atrophy? Again, it's looking at those lifestyle factors, going through them one by one. We've got an interesting one coming here. How can we help single women who've never had a sexual experience to have healthy menopause?
So this is where knowledge is power. And there's some really great books out there. And I can certainly send you a list of recommended reading material. But one of my favorite books about female sexual health is a book called Come As You Are by Emily Nagoski. And it's a great book at explaining, you know, really, to paraphrase Nika Gaulbert, that women are not small men, that we have different sexual response cycles, that we have different stimulants and different phases of our sexual lives. So that's a book that I would strongly recommend having a look at. Self-exploration is fantastic. Christian Northrup writes about this a lot in her books. You don't need a partner for a satisfying sex life. In fact, Christian Northrup, in one of her books about menopause, wrote that the best predictor of good sexual function at midlife is a new sexual partner, but you can be your new sexual partner yourself. You know, there are great tools, obviously, for self-exploration, you know, hand mirror, vibrators, but just exploring yourself and finding out what you like. Is it watching Outlander? I mean, who doesn't love Jamie Fraser, you know? But finding out what works for you, what gets you excited and happy. There's there's going to be a video on my YouTube channel in about 2 weeks with 2 sexual health experts, and it's about the pleasure prescription for women, particularly women with vulvar pain, and how pleasure is really a fundamental, it's not an optional extra. It really, sexual health particularly, it's in Maslow's hierarchy of needs. It's one of our basic needs as a human being. And I think sometimes as women, we've been conditioned to think that we can't be sexual beings if we don't have a partner. And I think maybe it starts as being a sensual being, and really just starting to get back into your body again and finding out what you enjoy as a woman. But the Emily Nagoski book certainly will be a great place to start.
Yeah, great book, and absolutely a little bit of self-exploration. Yeah. Okay, any advice for vaginal atrophy other than lubricant and estrogen pessaries?
Yeah, so again, in the same way that our skin can get a little drier and more fragile, and we might need to change facial moisturizers at midlife, using a good vaginal moisturizer a couple of times a week, really great way to start taking care of that tissue. Look at what you're eating as well. Are you taking in enough healthy fats in your diet? Because those essential fatty acids are really important for keeping the skin happy and healthy. And vitamin C is really important for good collagen formation as well. So, your nuts, your seeds, your avocados, your extra virgin olive oil, and then, citrus, peppers. To find vitamin C rich food that doesn't irritate, say, your bladder. If you're dealing with issues like interstitial cystitis or bladder pain syndrome, sometimes citrus or peppers can be a little bit irritating. But there are so many different foods, particularly our vegetable and fruit friends, that are very rich in vitamin C. Hydration it's so basic and so important. I mean, we all know when we're dehydrated, if you pick up, back in 150 years ago when I was a baby physio working in ICU, we'd go and we'd pick up the skin on the back of somebody's hand and watch how quickly it came back down again to see if they were dehydrated. So what's true for the skin up here is also true for the tissues down there as well. So oftentimes it is that fear of leakage maybe that can cause women to start restricting their fluids. And it's really, it will come back to bite you, because it can really just make those tissues even more irritable and dry and unhappy. So don't forget the basics. It's what you put on you, absolutely, but what you put in you in terms of nutrition, hydration, really important as well.
And apart from nutrition, hydration, and what you put in you in that way, any herbal medications for menopausal symptoms that you might recommend?
There is, but a couple of caveats with this as well. Just because a medicine is herbal or natural doesn't mean that it's universally safe, because if something is strong enough to have an effect on you, it is strong enough to interact with maybe other medications that you're having also. So I would be inclined to say, go talk to a good herbalist, talk to them about things like black cohosh, about red clover, about sage tea, because these all do have some evidence behind them. But a good herbalist will take your history into account and will also look at your medical history. Do you have blood pressure? Are you on any medications, for example? Because we really just want to be on the lookout for safety as well as efficacy, and any interaction between different medications. For example, St. John's wort, super popular, super powerful antidepressant, pain medication, but will interact with a lot of different medications. So yes will be the short answer, but do seek qualified help if you want to add some herbal medicines into your life.
Where do you source a good herbalist? Is there an association?
Absolutely. So there is the National Institute of Medical Herbalists in the UK, and they will be able to steer you to somebody local who'll be able to guide you. So look for somebody who has a specific interest, obviously, in women's health. There's some great books out there on herbal medicine as well, so I can certainly put those on the book list that I'll send over to you to distribute as well.
Okay, all right. And so it's the same for supplements, isn't it, really? Yeah. Okay.
For me, honestly, food is medicine first. So you can't, I don't know who said it first, but you can't supplement away a bad diet. If you are not eating well, there's really no point in taking a lot of expensive supplements or herbal remedies. Are you eating a primarily plant-based diet? Because that just seems to be the most suitable for women going through menopause and into life after menopause as well. Are you taking in enough essential fatty acids? Have you got a good balance of omega-3s as opposed to omega-6s?
Yeah.
Are you drinking enough water? Are you reducing your sugar intake? Are you reducing your alcohol intake? Are you reducing your nicotine intake? As well as, of course, are you eliminating what you don't need? Because we are what we don't poop out, essentially. And our bowel is actually the pathway that we eliminate excess hormones. So a lot of the symptoms that women have going through perimenopause are actually probably driven by estrogen dominance. So both estrogen and progesterone come down at perimenopause and into menopause, but sometimes there's a relative excess of estrogen compared to progesterone. And that's where we can get a lot of the hot flashes, tender breasts, mood swings coming in. So your body wants to eliminate that excess estrogen. So your liver helps to break it down, and then hopefully we're having nice, happy, healthy bowel movements every day to get rid of it. And a lot of the research shows that women who have a primarily plant-based diet are more efficient at excreting that excess estrogen than women who have maybe a slightly more carnivorous taste. I'm not saying you have to go completely vegetarian, but maybe just, we generally advise that the size of meat, if you are having animal protein, maybe the size of the palm of your hand, that's a serving, not a big steak hanging off the sides of the plate.
That's going to be very surprising to people.
I know. So 3/4 of your plate should be plants, basically, and meat as a condiment a couple of times a week. The Lancet report that came out, a better diet for us and a better diet for the planet, really suggested that we, as a population in the Western world, we really need to look at decreasing our animal protein intake in terms of cancer, diabetes, cardiovascular disease, and Alzheimer's. And a plant-based diet really seems to be protective, particularly for women, because once we go through menopause, our iron needs are actually much lower. Premenopausally, when we're menstruating and losing blood every month, we can veer into iron deficiency if we are purely vegetarian. But once we go through menopause, that's not an issue for us anymore. Right. So making good choices about what you put on your plate is really where good health starts.
Okay, all right. So I'm mindful we're coming up to 3 o'clock, and I wonder whether we can have a little bit more of your time. What do you think?
Absolutely.
We've got a few more. Great.
Absolutely.
So you talked about the good foods that we could be having and a good healthy diet. Would it be the same for dry vulval skin or skin in general?
Yeah, absolutely. Yeah. Again, those essential fatty acids, your vitamin C, and hydration. Those are really so important for connective tissue generally, but your skin particularly.
Okay. All right. Highly allergic vulval skin. Moisturizing helps for itching due to atrophy and dryness. So far, I can only tolerate Vaseline.
Ooh. Okay.
Any advice on that?
Vaseline, I would just explore maybe some different options. I'm a big fan of Yes products, and I have no commercial affiliation with them whatsoever. The two products I find myself recommending a lot are either Yes or Relivium from Desert Harvest, which is an aloe vera based product. Really nice, got some lidocaine in it as well. And those are quite nice products. Vaseline is a petrochemical byproduct. It is still recommended by a lot of gynaes. if you're having that sort of super sensitivity, I would also always recommend maybe just looking up the chain a little bit. How's your diet? Are you eliminating, how's your gut health? How's your microbiome doing? Are you eating a nice plant-rich, diverse diet? Some of the guidelines say we should be aiming for about 30 different plants a week, which can sound like a lot if you're not eating a lot of plants, but break it down into something manageable for you. But I think oftentimes skin sensitivities, whether it's in the vulva, the vagina, anywhere in the body, often we need to go back to good gut health and see what's happening there. Are we eating well? Are we absorbing well? Are we eliminating what we don't need well? Because if we're not getting rid of it through the gut and through the bowel, then our body will try and eliminate it through the skin. And if you throw that into the mix with a scenario where there's decreased estrogen, the skin is a little bit more irritable anyway, I would look at, just maybe exploring what's going on from a gut health and a stress management point of view, checking for any constipation issues. But I think this is where it's really important that we don't just look at the vulva, that we actually look at the whole woman and see what's going on with her, taking a really good history and finding out how she's living her life on a day-to-day level, what helps, what irritates. And again, just doing good detective work to see if we can help her make good choices.
Okay. I've got a question here about atrophy and topical cream in a high-risk breast cancer environment.
Yeah. So that's a controversial one again. And topical estrogen would never be the first thing you would try in somebody who has a hormonally driven breast cancer. You would always do the lube, moisturizer, pelvic rehab, all those strategies first. There's very minimal systemic absorption of topical estrogen through the vulvar tissues, but there is some. And so this is where you have a fairly frank discussion with your oncologist about a risk-benefit ratio. With careful monitoring, if the quality of your life is so bad that it could be improved with topical estrogen, and you're doing a lot of very close monitoring to see what's happening there, is that an acceptable level of risk for you and your oncologist to have a discussion about? And that's kind of where the general thinking is, that it is a very individual decision, but if de-estrogenization of the tissues around the vulva is really impacting your quality of life, and you are making an informed decision, and you're going to be monitored very closely, I think that is a conversation that you would have, but it wouldn't be the first port of call by any means. But it is certainly, it's an issue that's being discussed in the literature on an ongoing basis over the past couple of years. So it used to be absolutely not, no way, never. And now it's sometimes maybe.
Okay. So have that conversation.
Yeah, absolutely. And remember as well that you are in charge of your healthcare team. So to go in armed with knowledge is power, and really to remember that you are steering the ship, and it is your body at the end of the day. We want you to have autonomy and self-efficacy and agency. So it's about having fairly frank and open discussions, and about coming in as equal partners with your healthcare team, not that sort of a power dynamic. I think that's really important.
Really important, yeah. Could estrogen be affecting the muscles around the groin and pelvic floor? Pain and coccyx too?
Yes. Estrogen affects pretty much everything. But again, as we were saying earlier, it can really affect tendons and muscles as well. And of course, the remedy is going to be a specific movement strategy that is bespoke to your situation. But yeah, absolutely. One of the things that, kind of, if we even circle back to the pudendal neuralgia question, sometimes women at midlife, if they're not exercising with intent and with focus, can maybe lose a little bit of muscle bulk, say in their glutes when they're sitting. And if you haven't got enough padding back there and you're sitting a lot, then that can actually start to irritate the pudendal nerve. And then it can also, be a culprit for constipation, which is going to further irritate your pudendal nerve because you're bearing down to have a bowel movement. Basically, just any question you ask is probably going to come back to bowel movements at this point. So what is the answer? It is about building appropriate levels of strength and flexibility and balance in around the pelvis. Just because you're going through menopause does not mean you can put on muscle tone. Of course you can put on muscle tone at any stage with a specific strength and training program. So it's really important that we don't just resign ourselves that it's menopause, I'm just getting older, this is my lot in life. Today's 50-year-olds compared to, say, 50-year-olds of 20, 30, 40 years ago, it's a different world. Women in their 50s now, we've got Jennifer Aniston, we've got Nigella, 50 is the new fabulous, And so menopause is not an excuse for living a diminished quality of life. And if you are suffering in any way, seek help, because there's help out there, whether it's your GP, your gynae, your pelvic floor physio, there are people out there to help you. And I think it's really important that we don't put up with pain and dysfunction when there's help out there for us. And sometimes we do have to be the squeaky wheel that shouts a lot till we get that help. But I think that's what we have to do, is empower women to speak up and say, no, this isn't right. Pain isn't normal. Pain is a sign that something needs attention. And if you keep ignoring that cry from your body for attention, it just shouts louder.
Yeah. Take action. Absolutely.
And obey.
How do I know how bad my hormones are off, and how can I regulate them?
How are you feeling? Would be the first question that I would ask. That's probably the best indicator. Rather than a series of lab results. It is, it can be quite informative to get your bloods done and to see what your levels are. But if you are going to your GP in the NHS, they're going to look at a very narrow range of blood levels for testing. That might not give you the bigger picture. At the end of the day, I think looking at yourself, how are you feeling? That's the best barometer of what's going on. I've had some women, and who've had, they've only felt better as they have moved through menopause. And for other women, it's been catastrophic. What's going on in terms of your thyroid? What's going on in terms of your mental health? There's so many different factors here. What can you do to keep living well? Eat well, move well, poop well.
I love that.
And sleep well. It is literally that simple. It sounds very simple. There are lots of steps that go into that. And, there can be socioeconomic barriers to eating well too, because I think there's never been a time when there's been more cookery shows available to us on TV or on the internet. But are we actually cooking? Because I think there is still a perception that cooking from scratch is expensive and a bit of a faff. And I think one of the greatest travesties that we have perpetrated in the Western world is the removal of home economics from school curriculum. Because when was the last time you used trigonometry? But we have to eat at least 3 times a day. And knowing how to shop well, how to cook, how to budget, I think those are such important life skills when it comes to lifelong health. And yet we don't rate them as highly as Archimedes. He's been dead a long
time. So we've got a couple more questions that have come in. How to improve bladder oversensitivity to cold? A slight draft or cold wind outside make me feel extreme urge to pee for the whole day or two.
Yeah. So sometimes that can actually be driven by what happens if, you say you come out of a sauna or it's super warm, you're at the beach and it's really warm and you run into the cold sea or you dive into like a plunge pool of ice. What happens to your whole body? it tenses up. So if a cold breeze comes along or you're suddenly caught in the rain, what can happen is your whole body tenses, pelvic floor tenses, but maybe you're bearing down a little bit on the bladder as well. And that can just push it down a little bit and squeeze a little bit of urine out, or make you feel like you're going to leak as well. So the first thing to do is, if you're anticipating getting cold, because it's been beautiful weather for the past couple of weeks, but we all know that summertime in this part of the world is notoriously unpredictable. And as they say in Game of Thrones, winter is coming. Making sure that you have layers on, and if you get a sudden chill, that you're not bearing down, okay? That you're relaxing the pelvic floor, that you're not carrying that tension and pushing down, that you're actually consciously aware of being supported in your pelvis, which hopefully you will be if you've been doing your pelvic floor exercises properly and you're not constipated.
Okay, great. And then one final one here. Do you ever recommend natural progesterone cream for endometriosis or too much estrogen? If so, would it just be for a short-term use, not long-term, and for perimenopause?
So there's a couple of different things in there.
Yeah.
The gold standard treatment for endometriosis is surgical excision, followed by pelvic rehab. You do not want to suppress the disease with hormones, with birth control pills or Lupron. You want to actually take the disease out. Hysterectomy is not a cure for endometriosis, which is the growth of tissue that is similar to, but different from, the lining of your womb in places outside the pelvis. So for a long time, hysterectomy was offered as a management strategy for that. And it doesn't work as a management strategy for endo, because the endo can come back. The disease itself needs to be removed. And if someone's having a hysterectomy, then they have to deal with all the fallout from a hysterectomy, which is a very casually done surgery to women that has enormous implications for heart health, brain health, bone health, and mortality as well as morbidity. So that's a whole different discussion that we could have. The progesterone creams that you can buy in, say, a health food shop are based on wild yam. It is not bioidentical progesterone. The wild yam that they use in progesterone creams that you get that are pharmaceutically compounded and graded is converted in a lab into bioidentical progesterone. If you are buying it in a health food shop, you are probably just buying an expensive moisturizer.
All right. So, you know, what I've taken from this, I think I've taken a lot from it, but eat well, move well, poop well, sleep well. I think that's going to stick with me. So in terms of resources, you're going to send us over a list, which perhaps if you can get that through to us, I can put that in the email tomorrow together with the replay. Is that doable?
That is feasible.
Brilliant. And so to wrap up then, what's your top tip for menopausal well-being?
Pay attention to yourself. You know, and take care of yourself. Listen to what your body is telling you. Listen and obey, because your body will always win. But don't make it shout too loudly. You know, just pay attention to yourself. Prioritize your self-care. If something doesn't feel right, seek attention for it and don't get fobbed off. But do the work. You have to do your work as well, which is eat well, move well, poop well, sleep well. If you are doing everything right and you're still not feeling well, then it's time to take it to the next level and get some answers.
Right. Yeah. Brilliant. Thank you so much. Michelle, brilliant. Before I tell everyone who's on next week, just to say a thank you to everyone who's donated. It means that we can continue running these. After this webinar, there'll be a donations page that comes up. If you're watching the replay, there'll be a link towards the bottom of the screen. Any small donation if you can. It's really appreciated. And our website's getting a makeover at the moment, something that we've been working on in the background. Once it's live, all the webinars, and so we've now, including you, we've got 9 in total of these new webinars. These replays will go on the new website. But in the meantime, if you want to have a replay of any of those or find out what we've covered, because there's quite a lot of topics on vulval pain, then get in touch with us.
info@vulvalpainsociety.org.uk.
And then we'll be getting more up-to-date resources, information on the new website too. But for now, you've got our current website, which already contains lots of fabulous resources. So next week, when we ran a poll to ask which topics to cover, this topic was really popular, and it's pain self-management. And I think that ties in really nicely, Michelle, to kind of paying attention to yourself and, what's your body telling you? Listen to your body. So pain self-management. Our expert next Friday the 12th at 2 p.m. is Pete Moore from Pain Toolkit. I can't think of anyone more suitable to answer questions on pain self-management. So the sign-up link is going to be emailed out tomorrow. And what we're going to do this time is, for the first 30 people who register, you can ask your question in advance. After that, we're just going to take questions live on the day to keep it really interactive. If you follow us on Facebook or Twitter, you'll see sign-up links on there too. And I really, really hope you can join us for this one. You asked for it, we're going to deliver. So today, thank you again, Michelle Lyons.
Pleasure. I'm absolutely delighted to be here. And thank you for all you do, because I think it's so important to help women with chronic pelvic pain, because so many women think they're the only one. Yeah. And it's great to have a network like this to support them. So I want to really encourage everybody to make a donation to support the work that you do.
Oh, thank you, Michelle. That's lovely. So hopefully we'll see you again, because I think we're going to have more questions on this. It's such a wide, broad topic, but certainly eat well, move well, poop well, sleep well. And on that note, thank you all for joining us, and see you next time. Bye for now.
Bye-bye.